Dear colleagues, this is Desiree Wussler from Department of Cardiology and Cardiovascular Research Institute in Basel, and I welcome you to my presentation about the direct comparison of BNP and NT-proBNP for mortality prediction in patients with acute dyspnea. Despite a multitude of studies, it is still unclear whether BNP or NT-proBNP, their admission or discharge measurement, or even their percentage change during hospitalization are preferable for mortality prediction in patients with acute dyspnea and acute dyspnea due to acute heart failure. Therefore, we directly compared BNP and NT-proBNP regarding their potential in mortality prediction. In a prospective multicenter diagnostic study, the presence of acute heart failure was centrally adjudicated by 2 independent cardiologists among patients presenting with acute dyspnea to the emergency department. BNP and NT-proBNP levels were measured at presentation and before discharge, and patients were stratified according to their natriuretic peptide response as follows. Responders versus non-responders showed a natriuretic peptide decrease greater equal 25% versus lower than 25% before discharge, respectively. Among 1,156 patients presenting with acute dyspnea, more than 30% died within a 720 days of follow-up. As you can see in both displayed figures, the prognostic accuracy for death at 720 days was significantly higher for discharge BNP levels as well as for discharge NT-proBNP levels. When directly comparing discharge levels, NT-proBNP levels showed a significantly higher prognostic accuracy for death at 720 days. Among all included patients, about 50% were BNP and NT-proBNP non-responders. Among BNP and NT-proBNP non-responders, 32 and 35% of patients died within 720 days of follow-up. After adjusting for common covariates, NT-proBNP non-response was the strongest predictor for 720-day mortality in a Cox regression models. These results were confirmed in 687 patients with adjudicated AHF. To conclude, percentage change of NT-proBNP during hospitalization seems to be the strongest predictor for long-term mortality in patients with acute dyspnea and in those with dyspnea due to acute heart failure. I thank you for your attention and I'm now open for your questions.